A very good morning to all of you. Welcome to the last lecture for this year, organized by the Doctors Welfare Society of LRH. We have been conducting lectures since last December, clinical lectures, monthly clinical lectures held on every Wednesday. And this is the 13th episode we have in the series we have started since last December. So today's topic is constipation in children, approach and management. Before moving on to the lecture, I have to make a small announcement. The Doctors Welfare Society is organizing an annual friendship dinner, which will be held on 13th of December from 7:30 p.m. onwards at the World Sports Club. That is a Tamil Union Sports Club, which is very close to the LRH hospital. And the registration link is just displayed outside. Just poster. You can scan the QR code and get yourself registered for the event. So all of you are welcome. And the tickets are currently being issued at the LRH Photocopy Center. The channel is there. You can buy the tickets from there. And there will be several good activities, and you can enjoy the night after a hectic year, I believe. So all of you are welcome to the annual friendship dinner of LRH organized by the Doctors Welfare Society. So moving on to today's lecture. Our lecturer is Prof. Shaman Rajindrajith. All of you know him very well. So I'll give him a brief introduction. Prof. Shaman Rajindrajith graduated from the University of Pune with flying colors and pursued his postgraduate studies in the field of pediatrics after joining as a lecturer of pediatrics at the University of California. He completed MD Pediatrics in 2002 and became a board-certified consultant, subsequently a professor in pediatrics, then became the professor and chair at Faculty of Medicine, Colombo, the year of 2018. Dear sir, over to you to conduct your timely lecture. Thank you.
Good morning, everyone. And I'm very thankful to the Welfare Society for inviting me to give this lecture on my favorite topic of constipation. This lecture, I'm leaving it in this computer. Anyone who wants, you can take it home. And my only request is spread this knowledge to everyone that comes across, and so that we can standardize and we can do the justice to children with constipation. So the lecture is all yours. It's in this computer. Download or whatever. If you can share it with your colleagues, the Welfare Society, or whatever you have, your whatever it is, you just share it, right? I don't need it anymore, right? So we will just talk about hypothetical child. I'm sure you have seen somebody like this at least several times in your lifetime. So 4-year-old boy presented with the history of reduced bowel frequency once in 5 days and hard stool for 6 months duration. The mother also says that the child refuses to pass a stool in the potty and stiff his body when there is a desire to pass a stool. On examination, the clinician found a well-grown child. The abdominal examination reveals a large fecal mass in the lower abdomen. The rest of the systemic examination is unremarkable. So all of us have seen a typical child with constipation comes with this section. So they have hard stools, infrequently passing stools, and most of the time they are not toilet trained. And when they have a desire to pass stools, they stiffen their body and cross their legs and stop passing stools. So this is the classic way of presenting. So ladies and gentlemen, that with that preamble, I'm going to ask you a question. What is childhood constipation? So to find the answer to this, I think the best way to interpret this is like this. All of you know the story of elephant and 3 blind men, right? So the one in brown suit would tell elephant is like a pipe, right? The guy in the gray suit would say elephant is like a wall. And the guy in the brown blue suit would say elephant is like a rope. It's like that, basically speaking, simply because for various people, it's, constipation, rings a different bell, right? So this should not be the case in the 21st century. So you can define constipation very clearly, and you can identify these children very clearly, and there is a very clear pathway of treating these children and finish the business within 3 months. So since this has been going on and there are no ways to do research and anything, so the experts of pediatric gastroenterology and neurogastroenterology had decided to define constipation. So constipation definition start in Rome 2. Rome 2 was published in 1999, and then the Rome 3 came in 2006, and the Rome 4 came in 2016, and Rome 5 will be out in 2026. So basically, what happened is they regularized the definition very clearly. So look at this. So Rome 4 criteria currently, defecation frequency less than 2 times per week, fecal incontinence more than once a week at least, and retentive posturing, that is crisscrossing the legs and stop passing stools, and painful or hard bowel motion, large diameter stools, fecal max in the rectum. Criteria should be fulfilled at least once per week for 1 month. We are not going to wait. In the Rome 3 criteria, it was 2 months. We thought it was too long actually. Should not a child should not suffer 2 months before diagnosing constipation. It's then and there you can diagnose. So there can't be much of a organic disorders. In fact, in Rome 5, this will stay the same. So there is no change for next till 2036 actually for the diagnosis. Right. So this is how you define. So you can always then, and if you go back and read that history, we can find two very clear criteria to define constipation. So how common is this? What's the epidemiology of childhood constipation? So we were told that constipation is not there because we are eating fruits, vegetables, and all sort of things, right? But this is the global epidemiological picture, right? So you can see here, basically, this is Sri Lanka. Then this is Nigeria actually. So these are the certain areas where they have done epidemiological surveys, and this map need to be updated in next year, which we are planning to do. So according to this systematic review and meta-analysis, the global pool prevalence is roughly about 9.5%. So globally, at least around 10% of children are suffering from constipation, right? Well, look at, if you break down and look at these things very closely, look at, so basically, this is the epidemiology of constipation outside Asia. So look at the Western countries we are having. So Netherlands, US, Turkey, all these things, numbers you can see. But see what the numbers in Brazil. See the numbers in Nigeria. Those are not typical Western countries, right? So the Nigerian study, I contributed to this study. See, we found actually 27.3% of children in Nigeria having constipation. So look at what is happening in Asia. So Hong Kong, 29.6. Hong Kong second study, 28.8. Look at Taiwan, right? And look at Sri Lanka, 15.4. So my question is, constipation is not anymore a disease of the Western world. The epidemiology is changing so rapidly. And my question is this: is epidemiological epicenter shifting from west to the east? Right? So we do have more constipation than anybody across the world. So there are 1.2 billion children living in Asia Pacific region as a whole, right? So the total that is amountable to 53.5% of global childhood population, right? So we have Asia Pacific region have the highest numbers of children So if we have epidemiology at least 10%, we are far exceeding than the West with regards to numbers, right? So we are, the Asia Pacific region is the epicenter for pediatric constipation. So the argument is although it has been told, this has been implanted in our heads. ඕක සුද්දා කියලා. Not anymore. Not anymore. Right? So that's it. That's not it. So the second question that we need to answer is what is the etiology of childhood constipation? So people are so worried about the etiology. Why my child is getting constipated or what? So let's look at that. Now, I'm going to challenge the common belief of organic causes. Now, what do you guys do when you get a child with constipation, right? What we do is do the thyroid function. And, some enthusiastic registrars would do livid. So, would do calcium, celiac screening, all sort of things, right? Common in the private sector, when you are practicing, you do. Almost all of people do check thyroid functions, right? Actually, organic causes leading to constipation is extremely rare. No doubt. Keep on doing 1,000 times a thyroid function test, you are not going to get. Because majority of children with hypothyroidism have normal bowel function. I'll show you that. Right? So over 95% of children have functional constipation. Organic causes are only 5%. You can recognize them. I'll show you how to recognize them. So let's look at the pathophysiology of this common disorder. Right? Here, you have the normal rectum. This is what happened when the fecal mass comes. And if it is enlarged up to a certain degree, then the rectal wall stretches and tells the body that fecal matter is inside the rectum and it is the time to pass the stools. So then they evacuate, right? So what happened in constipated children, as I said, is something totally different. Now, they don't pass the stools for some funny reason. Pain, fear, rejection of this thing, struggling with parents and all that stress. Whatever the reasons, some reason, they refuse to pass the stools. That is the major problem. When they refuse to pass the stools, they squeeze their internal and external anal sphincter and don't allow stools to come out. That is why they sometimes stiffen their body, hide somewhere, crisscross the legs, and stop passing. That is exactly what they're doing. So now, if they keep on doing that, see what is going to happen. So the fecal mass get accumulated inside the rectum, and the rectal wall stretches. It has, stretches and keep more stools as soon as it accumulates a great large fecal mass. And the rectal mucosa is designed to absorb water from the stool. So no wonder they develop hard stools, right? No wonder they develop hard stools. That's very obvious. So they crisscross the leg and then they don't pass. So they develop this large fecal mass, which is dry and hard. When this passes, it causes excruciating pain because hard, large fecal mass. Right? So what happened? Then that aggravates fecal withholding anyway. If there is a pain, they are not going to pass the stools. So they hide somewhere and cross the leg and wait. So it goes like a perpetual cycle, vicious cycle, till the rectal wall get dilated and rectal hyposensitivity develop unless we treat it. And when they develop rectal hyposensitivity, then it's extremely difficult to treat these children. So you have to catch them early, right? To catch them early before they go into complications. So this is the pathophysiology. If you want to remember one slide of my lecture, I would be very happy if you can remember this. Because all management, investigation, everything is depend on what you know of the pathophysiology. So this doesn't have to have thyroid function business, right? This has nothing to do with thyroid. This has nothing to do with hypocalcemia or hypercalcemia. This has nothing to do with neuronal intestinal dysplasia, which is big. So this is simply stool withholding, right? So that is the pathophysiology. And what are the risk factors? Well, these are what are the risk factors, right? So the male gender has a small high risk factor. This is some study that we conducted in 2009 and published in 2012. You can see male gender has a slightly high risk of developing constipation. And dietary fiber. Several studies have shown that dietary fiber is a risk factor. Poor intake of dietary fiber is a risk factor of constipation. There are enough studies. So the normal fiber intake, Pearl can tell us, she's here. The rough idea is quite easy to calculate things, right? Normal fiber intake is 8 in years plus 5 grams. For a 2-year-old child, you need minimum of 7 grams, right? So something like that, right? So dietary fiber, low dietary fiber is a very clear risk factor. But ladies and gentlemen, remember that doesn't necessarily mean high fiber diet will alleviate constipation symptoms. If you can remember the pathophysiology, if you give a high fiber diet to that the picture, the fecal mass will get larger. So we would recommend normal fiber diet. So don't make matters worse by giving a lot of fruits and vegetables. It might not help you, and it might, at least in theory, would aggravate symptoms. So junk food. This study is a very lovely study from Taiwan. They say very clearly, right? So, sorry, Hong Kong. Yeah, consumption of fast food and development of constipation. Very clear evidence, no question. Psychological factors, psychological stress. Some of our studies show very simple psychological stresses like, school related and home related, right? Separation from a breastfeed, failure in exam, right? Severe illness in the family. They are not major stresses, right? But still, tiny thing can push them into developmental constipation because the brain and gut have a constant dialogue through millions of neurons, right? Through the spinal cord, right? Apart from the brain, gut has the highest number of neurons. So they have an absolute constant dialogue. If something goes wrong in the brain, it definitely reflects in the gut. Well, simple things, right? And the last point is living in war-affected area. We were crazy enough to go to war-affected Eastern province at one point in our younger life and did a study on constipation that was found to be very clearly highly associated with, children were there with a lot of constipation compared to Western province and the Southern province. So we compare the three provinces. Funny. So this is the other one I want to highlight. So child maltreatment and constipation. Constipation is associated with all three forms of child maltreatment, major child maltreatment, like physical abuse, emotional abuse, and sexual abuse. You can see the p-values statistical right now. This is one of my studies which we published in 2000. So, psychological maladjustment and constipation. So we conducted this study. Actually, one of the pediatrician, her name is Nishadi Ranasinghe. Nishadi conducted this study to assess the psychological function and constipation. So what we found was basically children with constipation have a lot of psychological problems, right? You can see. So they have hostility and aggression, negative self-esteem, negative self-adequacy, emotional unrest, which is a whole gamut of problems. right? We published this in archives in the last 2017. So they have abnormal personality traits, right? So if you put all these things together, this is what it is, the basic pathophysiology and risk factors, everything put together. So stressful things, parental factors, disrupt microbiome, I didn't discuss that, genetic factors, and lifestyle factors, and psychological disorders, behavioral issues. All these things together lead to constipation. Right. This is the other important problem there, right? How should a child constipation be evaluated, right? This is where most of us go wrong, right? What is the evaluation? You do take a history and you do examination and do X-ray, do thyroid function test. That is what generally, in general, that is exactly what most of people do. But I would suggest you something different with some evidence, right? Look at this, right? What is this? This is the other, next slide is the other important slide that I want you to remember, right? So presenting features. So these are the, we discussed this. You can explain all these symptoms, right? All these symptoms, if you can remember my picture on that slide. Large fecal mass, right? Reduced frequency of breathing, pain while passing, fecal incontinence, stool withholding, large volume of stools, straining, bleeding PR, abdominal distension, all that can be explained, right? So these are the presenting features. Main component of clinical history, you take a good history of onset of symptoms, duration, time past meconium to exclude Hirschsprung disease, and detailed history of bowel habit, including stool frequency, consistency, fecal incontinence, withholding behavior, pain during defecation, blood in the stools, and then you come to family history, dietary history, past medical and surgical problems. Right? So take that. And main clinical features that you look for in physical examination could be growth parameters is important because organic causes, almost all organic causes would lead to poor growth, right? Poor growth. And dysmorphic features, there are enough dysmorphic syndromes that can lead to constipation. Abdominal examination, clearly look around the abdominal distension, scars, and fecal masses. And then perianal and rectal examination is again something very important. Nowadays, there are two schools of thoughts. Some people don't do a rectal examination. Some people do that. But when you do it, you get different set of information. Right. These are red flag features which indicate having serious organic disorders. You can understand this. I mean, bilious vomiting and delayed passage of meconium, blood in stools, failure to thrive, all these things are indicative of a trouble, right? Right. So how do we diagnose constipation? This is the most important slide in the whole presentation. Constipation is a clinical diagnosis. You don't need any investigation to find whether the fellow is having wrong criteria or not. It's so simple. 2 out of 6 wrong criteria equal to constipation. You don't need any investigation. Right? You don't need thyroid function test. You don't need abdominal X-rays. You don't need calcium. You don't need this any. Just a clinical diagnosis. Here we go. Most of the tests that you do have no role in day-to-day management of constipation. I will go through one by one, at least for few things, right? All of you do abdominal X-rays, right? Most of the time, if you are from surgical side, they do, right? Abdominal pain, constipation, you do a abdominal X-ray. Now, do you guys? So now they say, by doing that, then they say there is fecal mass in the colon. Now, what is colon? What is colon? Why? What is the function of colon? Colon's main function is store the stools and keep it there till socially acceptable place can be found to eliminate. Am I right? Very simple physiology. Right? So colon එකේ කක්කිය ඇරෙන්න වෙන මොනවද තියෙන්නේ? Why are people taking X-rays and look at, oh my God, you have colon, feces in the colon, and therefore you have constipation. Now, how do we diagnose constipation? Clinical diagnosis. X-rays has nothing to do with this business. I will tell you a nice story, right? There are 6 scoring systems in this world. Brighton method, Starwell method, there are so many, right? To assess the amount of feces in the colon. Now, anybody use that system? At least, do you all know there is a system to assess? No, you just take the X-ray and like a big shot, look at this one. The stools. So there is constipation. Now, this is 21st century. We have science. We have clinical ability. That is not the way to diagnose constipation. So, by diagnosing constipation by looking at chest X-ray is not right. Although it is happening right throughout the late, except ward one, we don't do. Right? So I can go on and talk about the X-rays and constipation in a different lecture for 40 minutes. But the point is, constipation is a clinical diagnosis. Be a clinical animal. That's the best way to live. Not depend on any of these industries. So the point is, Netherlands, they have conducted a very nice study. So they took a few children with constipation and few normal children and took abdominal X-rays, right? And got down several radiologists. So first round, they give it to X-ray go to radiology, radiologist Y, X, Z, then they were asked to, radiologists were asked to do a scoring of that particular X. Then after a week, they were given it again without them knowing what X-ray that they are getting. Right? So the score system, there is no intra-observer reliability on any of these scoring systems. Then they found something very interesting. Then they found there is no intra-observer reliability also. That මෙයාට දීපාලට දුන්නාම දීපාල 10ක් දෙනවා මහින්දය දෙනවා 5. So there is no, these are not very objective. They are all very subjective. So interpreting X-ray for constipation is one of the most difficult things that if you ask me to do. Right? So why are we bothered about doing X-rays? Then no problem. So, some people, do it for parental satisfaction and this and that and the other. Why are we exposing child to a radiation? Do we get adequate advantage of doing that? No, you're not going to get anything other than your clinical diagnosis. Clinical diagnosis confirm karanone. You don't have to do that. You just, So similarly, next thing you guys do is thyroid function. Look at this, right? This was from US about 10 years ago. They have done this. 873 thyroid function tests. 56 had evidence of hypothyroidism. 9 had clinical significant hypothyroidism and constipation. 1 had constipation as a presenting feature. The majority of hypothyroid patients had normal bowel. Would you do thyroid function test? No point. There's no. The validity is very less. You're not going to catch a hypothyroid by, wait until them to present with constipation. Now, if you do a proper clinical evaluation, you would have find it long before without doing thyroid function. So that is the other argument that I put forward. So, right, colonic transit studies. This is sometimes valuable in therapy-resistant constipation to see what is happening. This can be done in Sri Lanka. We have radiopaque markers at Ragama. We can do this. So basically, you can assess total and segmental colonic transit times. Right. So total transit time over 60 hours is, suggestive of constipation, basically. Right. So look at this X-ray. Like you can see this right here in the in this X-ray, where you can see whole thing. The most of the radiopaque markers are located in the anorectal region. So this most likely rectal hypofunction or withholding. Now here in the other one, you can see pan-colonic distribution of radiopaque markers. Here in the proximal colon, this is the distal colon, this is the rectosigmoid area. So this one has probably pan-colonic dysmotility. This can be done, right? So these were old stuff. What are the new stuff? What are the new investigations that we can do? This is the new fellow from the blog, right? High definition anorectal manometer. You can do anorectal manometry. It's quite simple procedure. You can do it in older child. I generally do it for 8 or 9 or 10 years, 8 years above. They can comprehend what to do and what not to do during the test. So we generally insert a balloon into the rectum and then inflate, mimicking the stool is getting loaded in the rectum. So then what should happen? There at one point, the internal sphincter should relax, right? And then external sphincter should relax and the feces should come out. And then they are asked to bear down to see whether they can expel the balloon. So those are the things that we see. So we can see sphincter function, rectal sensation, continence, rectal compliance, all sort of things can measure, and we can find children with anorectal dysfunction. And actually these children exist. So the best example, about a week ago, I saw a child, about 10-year-old boy, who was resistant to all sort of therapies. They are gone to 4 pediatricians, right? The question is, he has well toilet trained, right? Has no organic disorders on physical examination. Then the clue was he was straining quite a lot. So I thought he would be having anorectal dysfunction, discoordination of the mechanism of passing stools, and then simply because of that he cannot pass the stool. So what I did was I asked one of my colleagues who does anorectal manometry to do anorectal manometry. Yeah, which is called dysynergic defecation. Dysynergic defecation means the synergic defecation is when the rectal balloon is distended, the internal sphincter and external sphincter relax. The dyssynergia occurs when you don't relax the sphincter mechanism when the rectal balloon is distended. So it cannot happen. So they can't pass a stool. So how are we going to treat these children? You need to relax their external anal sphincter only by two methods. One is biofeedback. You can train these children. The other one is botulinum toxin injection and give it. So you need to think innovatively to treat certain children. So this is very important. Actually, we can do it in private sector or we can do it at National Hospital. Dr. Dakshita Vikramasinghe is doing it at National Hospital. You can get it done actually in a child who is refractory. Yeah. We are trying to get down the machine to Lady Region Hospital is 40 million. Trying to, one day before I leave, I'll do one. So then the other one that you can do is high resolution colonic manometry. You can insert a catheter into colon and measure whether there are adequate contractions. These are for refractory cases. Right? So you can see whether they have high amplitude propagatory contraction, which is the moving force of the colonic musculation, and whether you can see a cyclic motor pattern. So you can show colonic wave sometimes you can give some bisacodyl after certain times and see whether you can augment these waves. So all sort of things you can see. So high resolution colonic manometer. The other one. These are the tests that you do if you ever want to do tests, not thyroid function and exercise. Right. The final part, how are we going to help these children? How are we going to help? What are the common things that we do? So this is my management paradigm, right? So you do lifestyle modification, you do behavioral, modifications, and you can do laxatives, you can do rectal evacuation, then you can do physiotherapy biofeedback, and you can do neuromodulation, and then we can ask our surgical colleagues to help us when we are in trouble. So we'll go through this very carefully. So first thing, if I get a child with constipation to my clinic or wherever I sit down, I would explain all these things. I will draw a couple of diagrams and show them the rectal fecal mass and how it works and how, what it is, right? Nature and pathophysiology. Then interpretation of investigation. If they brings any, I don't do any, right? Then I tell them exact management plan. So by doing that, you can develop confidence in the patient. They know this fellow is talking some sense, right? And then they believe what we say, and they follow my management plan to the last letter, so that we can cure constipation within 3 months. In our clinic or whatever I see patient in government private sector, after 3 months, I tail off the drugs and stop. Right. So this is the secret. So you tell all these things. Sit down, take your time, right? And the problem that we have is I don't know how we develop. Most of people think that patients are our enemies. Don't think like that. This is a golden opportunity to help someone. To මේ මිනිස්සුත් එක්ක කේන්ති ගන්න. මම වගේ ඉන්න. දීපල්ස වගේ නමට දෙන්නේ. See, the whole thing is look at in a totally new way. They are asking for help. They need it. That's why they are here. So I would take, actually, if I get a consultation, I would spend 15 minutes. Because I know that's an investment, because I don't have to see them again and again and again. And I finish the job by 3 months. So this is how I do. So toilet training, that is the first thing that you need to do. Most of you treat constipation properly. I agree. But none of you talk about toilet training. First thing, imagine you can give tons of laxatives, gallons of polyethylene glycol. But if the child is standing and stiffening his legs and contracting the external anal sphincter, are you going to be successful? Answer is very clear, no. First thing in treating this 4-year-old child whom we have discussed with constipation is get them sit down and potty train. You just talk to majority of people come with constipation. Most of them have not potty trained their children. Potty training can be started after 1.5. So the story of fiber and water. So most of you guys ask people to take a lot of fiber, right? Drink a lot of water, thinking that making the stool mass large would help you to pass the stool. It doesn't work that way. You see the problem. You can remember the slide. It doesn't work. They are withholding. What's the point of giving more fiber, and making that stool mass larger? It makes it passing you more difficult. Water. Drink a lot of water. Liter a bag more. What is the colon function? Absorb water. Large intestine and small intestine is designed to absorb water. So all the water that you give will be absorbed from the proximal, absorbed at least in the distal small intestine or proximal colon, and increase urine output rather than stool output. Think rationally. Can you dissolve that hard fecal mass by giving water? It's very difficult. It doesn't work. Try. So, although, I agree with you, low fiber diet is a risk factor. But so how do you approach? Give a normal fiber diet. So age plus 5 in grams a day. If the fellow is eating low fiber diet, ඔක්කොම ජංක් කාර්යයට මේට නෙමෙයි තමයි මෙච්චර පළතුරු මෙච්චර ප්‍රමාණයක make it like this. Give the normal level. Don't have to do that. Right? So probiotics doesn't work. Although whatever the probiotic company says, it doesn't work, honestly. Right? There's no evidence that it works for constipation. It works for abdominal pain. That's a separate lecture. We'll do it in a separate. Right? Now, there are only 3 things in the management of constipation. Now, if you don't evacuate that large fecal mass in the rectum, would you be successful in treating? No. So, first thing, to take off that large fecal mass, how are we going to do that? By giving polyethylene glycol. That's the best drug which is available, actually. So I have written so many letters that it will be available at a clinic level, right? We are ordered 10,000 sachets. Please use. Right? I will fight for my last breath to get down polyethylene glycol to the hospital, and I'm partially successful tender recognition. So it will come. Please use it, right? So if you give a bit of a higher dose of polyethylene glycol to a child, the fecal polyethylene glycol is a non-absorbable osmotic laxative. In today's literature, it is the most potent laxative, osmotic laxative in the world. Right? It's non-absorbable, so it absorbs water from the surrounding tissues into the gut, dissolve the stools, and make it absolutely easy to pass if you sit down in the potty. Right? So do that. So give that less pain, discomfort. Nothing much, I was 100% successful up to now. If I can't get it from once a day, I would use one sachet twice a day. It works definitely. I have never had any necessity to give more than 2 sachets. Right? You can calculate and give it, but this is a rule of thumb, basically. Right? So the rectal route is used when the oral route fails. Right? Don't put suppositories, enemas, not really necessary. That makes matters worse, right? Right. So you put suppositories, right? Make it very painful because there can be already, anal fissures and, difficulties. They give suppository and you make matters worse. The fellow withhold stools more and more. You put microenemas, the same thing. Why bother when there is a very nice oral drug that works? You don't give suppository business. Don't go to any mark. Don't be too aggressive. It's very simple. I'll tell you how to prepare this. So don't put this sachet is supposed to be dissolved in 125 ml of water. So what I do is make it very child friendly. I dissolve it in 100 ml of water and add 25% of their preferred fruit juice. Make it absolutely orange juice or apple juice or guava juice or whatever they like. And they drink. Right? And so that is what, make it child friendly. We children, we are dealing. So that is what we do, fecal disinfection. And when you evacuate that rectal fecal mass, then you maintain it. Don't allow it to get reaccumulated. This to be done by using polyethylene glycol or, osmotic laxative plus or minus stimulant laxative and toilet train. Right? So they need to be toilet trained. Keep on toilet trained. Keep on asking them to sit 3 times a day in the potty. And then you use low dose polyethylene glycol, right? And if that doesn't work, add a small dose of stimulant laxative. Don't use stimulant laxatives alone to treat constipation. It doesn't work in that. Oral bisoprolol alone won't help you. Hmm? So combine, right? The duration is generally variable. So I think at least we have to give it 2 to 3 months for that little brain of your constipated 4-year-old child, which we discussed at the beginning, to understand. To understand, passing stool is not a great big thing. You have to let some time to let that concept sink into their brain, and they are at ease after that. Then you gradually tail it off. Then you make it, every other day, and then you gradually can stop. But take time. You can't cure constipation in 2 weeks. It doesn't work. It relapses, right? So that is what it is all about. Lactatives that we can use. So as I said, polyethylene glycol is the first choice. There are 4 guidelines in this world. Aspergen guideline, Indian Society of Pediatric guideline, and Italian Society of Pediatric guidelines, Latin American Society of Pediatric guidelines, all recommend polyethylene glycol, not lactulose. Lactulose is good in my personal view is under 1.5 years. Over 1.5 years, you can use actually polyethylene glycol. Children drink. So what we are trying to get is polyethylene glycol 4000 without electrolyte, which is a very good preparation for us. So look, lactulose, magnesium sulfate, we don't use it anymore in this country. So we can use bisoprolol, senna, all these things can be used. But as I said, stimulant laxatives have a very minor role that need to be used with a combination of an osmotic laxative. Novel therapies, lubiprostone trial. Now there are 2 trials which was concluded. Glucuronide trial was concluded in 2018, and lubiprostone trial very recently concluded. These are new drugs. Glucuronide is a stimulant laxative, basically, right? So it's a 5-HT receptor agonist. So the adults have shown it is very effective for them. But pediatric trial failed. I'm sure this learned audience can understand why. We have no motility problems. In children, we have problems of stool withholding. They need toilet training and a simple stimulant, a simple laxative. Glucuronide didn't work. The trial fails. The lubiprostone trial recruited the highest number of children that has ever been recruited to any pediatric gastroenterology trial. 600 dollars, 400 cases and 200 controls. Fail. No benefit. Right? No benefit. Simply because our pathophysiological mechanism is not like adults. They're different. Try to understand. You don't ever forget my slide, the pathophysiology. Right? So, there are some more drugs coming out, right? But I doubt it very much that we will have very novel therapeutic agents, something coming from Mars to help us without toilet training. Okay. Right. What are the novel therapeutic interventions? So, sacral nerve stimulation. These are reserved for refractory cases. Refractory cases, right? So what we do is we insert an electrode to S2345, S234. Those nerve segments innervate the rectum and stimulate with this gadget. You press the button, they get stimulated, circuit completes, stimulate, and then the rectum contracts and the bowel gets open. So these are for refractory cases. But before doing that, you need rectal function assess and all these. A lot of things need to be assessed. But this works. This is a real therapeutic intervention. There are several trials that has been completed. Surgical intervention when we need Malik Samar Singh and the guy. Here we go. We can do lot with surgery. See, I said botulinum toxin for dyssynergic defecation, antegrade continence anemia, and sigmoid colorectal resection, proctocolectomy, and anal anastomosis in the most refractory case. Take the colon off if the colon is dysmotile. So before that, you need a very clear colonic manometry to prove that. You can't just take somebody's colon away without real evidence, right? So let's go through some of these things. See, this is antegrade continence anemia. You take the appendix, right, and bring it to the surface either through an umbilicus or through the right iliac fossa, and then you just right. So you see, this is the appendix. So then you insert a catheter through that into the cecum and flush it with either normal saline or normal saline plus some bisacodyl. You can flush it. It works very well in refractory cases, right? There are a few complications like skin infection, dislodgement, granuloma, and all that. So, but it works in certain children. The other one, this is one of my personal patients, right? This child came with severe constipation and failure trial. I thought this was Hirschsprung disease. Did everything, found nothing, including genetics. Then I decided, I had a chat with Mali, and we decided to do a barrier. This is what we found. A dilated sigmoid impacted with feces. Right? We treated, nothing works. Then finally, both of us thought we would take this segment off. The child is beautifully growing now. I don't follow up early. When you need the knife, you select the right patient at the right time with the right indication, then you can heal. Now, if I left this alone and try to work with my medical wonders, adding flucarotide, bisacodyl, whatever, this never helps. When the colon is get dilated, it doesn't go back and the segment becomes really hypomotile. It has no energy to push stools out. They all get accumulated. So before your patient come to this level, you need to aggressively treat and take them off. So yeah, whenever need to cut part off, surgeons are very happy to take things off. What is the prognosis? This is the other myth that most people think children outgrow constipation. They don't. If you don't treat properly, they suffer. Right? They don't outgrow. At least if you don't treat children properly, 1/3 of children will progress into adulthood with constipation. Right? You need to treat them aggressively and energetically to get them out of this mess. By the time they go to adult with constipation, their bowel is already damaged, done for. So therefore, we have absolute serious responsibility as pediatricians to treat them properly and to preserve their bowel function and to make sure that they go to adulthood without constipation. Right? So I'm finishing. So what I'm telling you guys is constipation is a major global public health problem. It significantly affects lives of children and their families. You see patient going from post to pillar, asking some POs, right? Risk factors are highly prevalent. Routine investigation do not help in day-to-day clinical management. Multifaceted approaches is the best way to manage children with constipation. Novel therapeutic options are available for children who are refractory to conventional interventions. Thank you very much for your patience. I'm happy to take any questions.
Thank you very much, sir, for your valuable lecture and allocating your time to educate us. And again, thank you for leaving this presentation in the computer to be shared among the participants today. So I would like to invite Prof. Shaman Rajindrajith again on stage, and Dr. Mahinda Vikramarachchi, Vice President, LRH GMF Branch Union, to present Prof. Shaman Rajindrajith with token of appreciation for his efforts and his valuable time today on spending us. And I'd like to invite Dr. Gayan Koditwaku, Senior Registrar Pediatrics, to present Prof. Shaman Rajindrajith with the invitation for our LRH annual dinner.
All right.
Again, thank you very much, sir, for coming with us today. And you can collect your lunch on your way out.